A pleasant good evening to all the members of the Marx Society. And on behalf of the Marx, I welcome you all to this webinar. Dr. Revati Madam, Dr. Yalini and Dr. Sunita and other senior members and other participants. And really it is indeed very great pleasure to share our experience through this panel as well as to talk with Sunita. And over to Madam Dr. Revati Janagram Madam.
Thank you, Dr. Sumati. It is a great pleasure to take part in this webinar. Dr. Sana, can you just share Dr. Sunita's CV? Actually, all of you know that RS prophylaxis is a far cry in India. Even though we say that every one of us know about this RS prophylaxis, still it is lacking, and we do get a lot of infant losses because of RS, with hydrops and so many things. But definitely we have done a lot of improvement. But today we are going to hear from Dr. Sunita how we are going to manage RS incompatibility. And following that, we will be having a fantastic case discussion on different varieties of cases of RS incompatibility and how we have to manage. And let us share this with all of you. Now, Sunita Prabhakaran is the director of Sumati Hospital, and I am very proud to say that her mother is our close friend, and really she was playing a great role in Madurai Wounded Society. And Sunita did her MBBS in Madurai in 1999, MD in IOG Chennai. She is trained well in laparoscopy, hysteroscopy, ultrasound, embryology, so many things, and she is doing infertility practice in Madurai. Her center, started by her mother, Dr. Manorama, is the first IVF center in Madurai. And Sunita has conducted a lot of workshops and conferences related to obstetrics and infertility and gynecology. And now she will talk about the RS management. Over to you, Sunita. Please share your slide.
Share my screen. A very good evening to all members of Madurai Obstetric Gynec Society. Respected Dr. Sumati Ma'am, President, Dr. Lakshmi, Secretary, Bharat Seeram for inviting me for this webinar. A special salutation to Dr. Sumati for her heroic efforts during these COVID times in managing the very busy labor ward of Government Rajaji Hospital. Good evening also to my respected chairpersons, Revati Madam, my teacher. I am proud to be presenting in front of her today, Dr. Yalini Selvaraj Madam, and respected members of the audience. So coming to the topic, when we come to the management of isoimmunization, it is important in two contexts. One, when a person wants to have repeated blood transfusions for some reason, like sickle cell anemia or thalassemia, and the other is when a woman wants to have a successful pregnancy outcome. Today we will discuss only the latter context. So isoimmunization or alloimmunization is when a woman's immune system is sensitized to the presence of foreign RBC or erythrocyte antigens in the fetus, leading to the maternal immune systems forming IgG antibodies, which then cross the placenta and destroy the fetal erythrocytes which have these antibodies, triggering a severe hemolytic response and disease in the fetus. Now, there are several antigens which can cause isoimmunization. The most important among these are the rhesus system of antigens, and the most important among these is the D antigen. By most important, I mean that this D antigen is capable of evoking the strongest immune response in the mother and therefore capable of causing the most severe hemolytic disease in the baby. So in general, when we say a woman is Rh positive, it means she has the big D antigen in her blood. And if she is Rh negative, there is no big D antigen in her blood. There are also atypical antigens, which we will get to a little bit later. Now the inheritance
Dr. Sunita, I'm sorry,
yes?
may I request you to please switch on your video? Your video has been switched off.
Video has been switched off.
Yes, madam.
You cannot see my slides?
The slides we can see, but not you, madam.
Okay. But it says it is broadcasting.
Your voice and the PowerPoint is being displayed, but your face is not seen.
I'll restart the broadcast again, madam. Is it okay now, madam?
You can't see.
We can see Sunita Prabhakaran. Not. I think.
We cannot see this.
Please proceed. It's okay.
Now we can see. Yeah. Start the slide.
Okay. Show the sequence. Can you see me on the screen, ma'am? No? Can you see the screen, madam?
Screen is okay.
The screen can be seen. But
Madam, please proceed.
Okay. Because for me, it is just showing as broadcasting only. I don't know what the problem is. Anyway, I'll just carry on with the presentation.
Continue.
So the inheritance of these rhesus antigens is by two genes which are on the short arm of chromosome 1. And the inheritance of these genes is important because the inheritance is closely linked. So it allows us to estimate the parental heterozygosity using gene frequency tables. That is, we can input data like ethnicity, blood group, blood type, previous Rh positive infants, and we can roughly guess the heterozygosity of the father. For example, a white male who has capital C, big D, small e, no previous Rh positive children has a 9% chance of being heterozygous, but the same male with small c, capital D and small e has a 94% chance of being heterozygous. So why is it important to know the heterozygosity of the father? Here in this picture, we can see that when a woman is Rh negative, she has no copies of the RHD gene. And when the father is Rh positive, he either has one copy of the RHD gene, which means he's heterozygous, or two copies of the RHD gene, which means he's homozygous. If he is heterozygous, only 50% of his children will be Rh positive, the remaining 50% will be Rh negative and totally escape from the total spectrum of hemolytic disease. Whereas when he is homozygous, all his children will be Rh positive and all of them have to be screened for hemolytic disease of newborn. So what causes isoimmunization? 90% of the isoimmunization as we know it is caused by the feto-maternal hemorrhage which occurs during delivery. That is the intrapartum feto-maternal hemorrhage. The 10% of isoimmunization occurs because of the antepartum feto-maternal hemorrhages which occurs in all these situations like abortion, ectopics, abruption and so on. It occurs because of a prior blood transfusion and rarely it has also been reported in cases of intravenous drug abuse. Now, do all feto-maternal hemorrhages cause isoimmunization? No. That is, 75% of Rh incompatible pregnancies do have feto-maternal hemorrhages throughout the duration of their pregnancies, and the incidence and severity of these feto-maternal hemorrhages increases as pregnancy advances. Yet 30% of these women don't become alloimmunized even when they are challenged with large volumes of Rh positive blood. So the alloimmunization depends not only on the occurrence of the hemorrhage, it also depends on how much of hemorrhage has happened, whether the mother has had adequate time to mount a response. So the maternal response is initially formation of IgM antibodies, which are not capable of crossing the placenta. Only later on, IgG antibodies are formed. And suppose the maternal immune response has not been good, or the maternal immune system has not had enough time to mount a response, or the fetus is only heterozygous for the D antigen, then alloimmunization may not occur in these cases. And suppose the baby has an ABO incompatibility associated with this. So if in ABO compatible fetuses, the risk of alloimmunization is around 16%, whereas in ABO incompatibility between the mother and fetus, the alloimmunization is only 1.5 to 2%, presumably because the mother destroys and clears these incompatible RBCs even before Rh sensitization can occur. So when we give this anti-D IgG prophylaxis, the incidence of this alloimmunization is reduced to less than 1%. So what happens when alloimmunization happens? We have a Rh negative mother, an Rh negative father, the baby is Rh positive. Suppose the mother has not had a prior sensitizing event, most of the times the first pregnancy is unaffected. The antibody response takes some time to happen. If the mother has already been sensitized, the second response to this Rh positive baby is much faster because of what is called the anamnestic response of the maternal immune system. So these Ig antibodies form in a much faster way. They cross the placenta, they destroy the fetal RBCs and trigger a long chain of hemolytic events in the baby, which is called hemolytic disease of the fetus and newborn. So this disease onset is during the antepartum period, but it continues even after the baby is born. That's why it's called fetus and newborn. So this is a wide spectrum. In the mildest instance, there can only be a mild hemolytic anemia because of destruction of RBCs. If the more number of RBCs are destroyed, then an excess of breakdown of RBCs happens. There is an excess of heme breakdown, excess of bilirubin. While the baby is inside the maternal uterus, the placenta can sometimes degrade this bilirubin fast enough. After the baby is born, the immature fetal liver cannot degrade this bilirubin. This bilirubin then deposits in the everywhere throughout the body of the baby, especially in the brain, and causes this kernicterus. Kernicterus is when unconjugated bilirubin is present in the brain of the baby. This causes poor feeding, loss of moro reflex, bulging fontanelles, incessant crying of the baby. Sometimes it even causes chorioathetosis and cerebral palsy. This is one instance of hemolysis. Then the hemolytic anemia causes the baby to mount an increased cardiac output to compensate for the hypoxia. This causes a high output cardiac failure. The hemolytic anemia stimulates the production of extramedullary hematopoiesis, which leads to a hepatosplenomegaly in the baby. The liver then starts losing its normal functions of producing protein. So there's associated hypoproteinemia. All this leads to an anemia, pericardial effusion, pleural effusion, ascites, anasarca, and leading to hydrops fetalis. So the spectrum can be anywhere from here to there. There are ways to predict hydrops. There are ways to treat this hydrops before it gets so severe. But even then, the prognosis of a baby who has hemolytic disease is only 84%, and the prognosis is better in a non-hydropic baby. So how do we diagnose maternal alloimmunization? As soon as the mother comes to us for checkup, we can do her ABO typing, her RH typing, and an indirect Coombs test to assess for maternal antibodies. Once we do this, we then have to assess the fetal risk for RHD. This is very important because if the fetus is RH negative, then we don't have to do any of these complicated methods of follow-up. So to determine the fetus status, the first thing we have to do is to determine the paternal status. If the father is RH negative, again, no extensive follow-up is required. If the father is RH positive, then depending on whether he's homozygous or heterozygous, there is always a chance that the baby will be positive. So earlier, there used to be only invasive methods for testing for the baby's RH status. We had to do a chorionic villus sampling or amniocentesis. CVS could be done by 12 weeks, amniocentesis at 16 weeks to assess the fetal grouping. But both these tests are invasive and they themselves cause a certain amount of fetal-maternal hemorrhage. So no obstetrician would want to do it unless the maternal antibody titer crossed a critical value of 1:16 or so. But now we have non-invasive testing like cell-free fetal DNA. In fact, the first use of cell-free fetal DNA was to assess the blood group of the baby. In Sweden, currently, it is normal process not only to assess the fetal RHD status, but they also assess the status of big C, little e, and big K, that is KEL, using cell-free fetal DNA. So this would be a very good way to assess whether the baby is positive or negative. In case this is not available or the expense is too much, then we have to settle for assessing the baby for anemia, and this is done by the middle cerebral artery Doppler in the fetus. We'll get to that a little bit later. So how do we diagnose fetal-maternal hemorrhage? So we have to have a high index of suspicion. Anytime we think a sensitizing event has happened, we must screen for fetal-maternal hemorrhage. Screening is by the Rosette test. And once we screen that there are antibodies and hemorrhage has happened in the mother, then we have to quantify the amount of hemorrhage. This is done by the Kleehauer-Betke test, acid dilution test, or even more accurately by flow cytometry. A brief word on these tests which we have mentioned. Indirect Coombs test is what is done on the mother's maternal plasma. So if she has been sensitized, she's going to have antibodies. What we are adding are the fetal, are the Rh positive red cells. So these will form complexes with the antibodies in the maternal serum. Then we add the Coombs reagent, which is the anti-human immunoglobulin. This Coombs reagent links all these antigen antibody complexes, showing up as aggregation when we check under the microscope. So if the maternal serum shows aggregation, it means the mother has antibodies in her blood. Then we have to quantify the antibodies and titrate them. Direct Coombs test is what we do for the baby. So here the fetal RBCs are coated with maternal immunoglobulin already. So we directly add the Coombs reagent or the anti-human immunoglobulin. Presence of clumps show that some kind of hemolytic disease is present. Now coming to the Rosette test, which I mentioned. In Rosette test, we are screening for feto-maternal hemorrhage. We are screening for the presence of fetal erythrocytes in the maternal circulation. So we take the maternal blood, we incubate it with Rh immunoglobulin, and this Rh immunoglobulin is tagged with indicator RBCs. So if there are fetal cells, this immunoglobulin will go and coat the fetal cells, and this is shown up by the presence of the tagged antibody, the tagged red cells in the form of rosettes. So if we see a rosette, it means fetal cells are present. Then we have to estimate how much of fetal hemorrhage has taken place or how many fetal cells are there. This is done by the Klehover-Betke test or acid elution test. The principle of this test is simply that fetal cells are resistant to acid elution. So when we take a smear of the maternal blood and subject it to acid, the maternal cells will undergo elution. The fetal cells, which you can see here, remain as such. So we can count the number of fetal cells and do a simple calculation which will show us the amount of feto-maternal hemorrhage. But however, this is inaccurate. If we do a flow cytometry, we can directly estimate the amount of hemoglobin F which is present in the maternal blood, and this is a very accurate method to assess the feto-maternal hemorrhage. Now, once we have diagnosed that the mother is either non-alloimmunized or alloimmunized, the management depends on whether she is non-alloimmunized or alloimmunized. A non-alloimmunized mother who is Rh negative, that means she does not have antibodies, she has not been immunized yet. It is very simple. The goal is to prevent immunization. You give her anti-D prophylaxis and follow the baby and deliver. An alloimmunized pregnancy, it means the mother has antibodies. So it means the baby is at a risk of hemolytic disease at any time throughout the pregnancy. So the fetal assessment is the main component of that management. We have to assess the fetus by using all these methods, follow up the mother, and try to avoid delivery until the baby has reached fetal maturity. Coming to the management of non-alloimmunized pregnancy, as I said, the goal is to prevent alloimmunization by preventing antibody-mediated immune suppression. That is, exogenously we administer anti-D immunoglobulin, and this acts by modulating the maternal immune response and decreasing the amount of sensitization. So the dose of anti-D which is given to pregnant women was actually calculated based on the tests done on male volunteers, male Rh negative volunteers, who were given various doses of anti-D to see when proper neutralization took place. So the dose they fixed was 300 microgram given intramuscularly. Initially, it was given after delivery because it was believed that most of the alloimmunization occurred at the time of delivery. But after that, they found that still alloimmunization was happening. So they decided to give it antenatally around 28 weeks once, and then again repeated postpartum if the baby is Rh positive. The exact calculation is that 10 microgram of immunoglobulin is given for every ml of fetal blood. Apart from these two blanket doses which I mentioned, that is one dose at 28 weeks and one dose after delivery if the baby is positive, we know that all these events like spontaneous abortion, therapeutic abortions, ectopics, and these invasive procedures, they all have their own risks of alloimmunization. For example, spontaneous abortion, the risk is 1.5 to 2%. Invasive procedures, it is anywhere from 7 to 15%. Any antepartum bleeding, it can cause even blood loss of about 30 ml. That means a full dose of 300 microgram has to be given. So the dose which we give, we take it like this. So if the baby is less than 12 weeks gestational age, the total amount of blood in the fetal circulation is supposed to be only around 5 ml. So if we give 10 microgram for each of these 5 ml, we get a dose of 50 microgram. So any sensitizing event before 12 weeks, a dose of 50 microgram IM is adequate to cover and prevent alloimmunization. Anytime after 12 weeks, if we suspect a sensitizing event has happened, we need to give the full 300 microgram dose. Even if we don't get the 50 microgram dose, it would still be safer to give 300 microgram rather than miss out on giving the anti-D at this stage. So although this method of anti-D prophylaxis was instituted in 1960s, and it is almost 60 years since, still, even though the amount of alloimmunization has decreased dramatically to less than 1%, it is not zero. Still, we are seeing cases of alloimmunization, and this may be because we failure to type each patient, screen them strictly for fetal-maternal hemorrhage. We don't give them anti-D when indicated, or we give an inappropriate dose. Next, coming to the timing of delivery. Now, this mother is not alloimmunized, so she can carry on till term. We must take care not to allow for postdatism because this increases the incidence of alloimmunization. And during delivery, we must avoid any maneuvers which can increase the fetal-maternal hemorrhage. That is, we must avoid giving oxytocics at delivery of anterior shoulder. We must avoid massaging the uterus or manual removal of placenta. And after the baby is delivered, we give a 300 microgram dose if the baby is Rh positive. And after that, if you suspect that the postpartum hemorrhage has been more, we must assess for fetal-maternal hemorrhage and then give an additional dose if needed. After, when we clamp the baby, we do an early cord clamping, and we leave about 15 to 20 centimeters of umbilical cord, so that in the event that the baby needs an intrauterine transfusion, this length of cord will be useful for the neonatologist. Coming to the management of alloimmunized pregnancy, there is no point in preventing here because she's already alloimmunized, she already has antibodies. So the goal will be to assess whether the baby is Rh positive or negative. If the baby is negative, there is no need for any further follow-up. If the baby is positive, our goal is to detect the fetal anemia as early as possible before fetal compromise occurs. We try to minimize the fetal mortality and morbidity and institute fetal intrauterine transfusion. We try to keep the baby going until the baby achieves lung maturity, and then we deliver. So here we individualize the treatment based on whether this is her first affected pregnancy or she has had a previous child with hydrops, whether the fetal antigen status is positive or negative, and what the maternal antibody titers are. If this is her first affected pregnancy, the maternal antibody titer is of paramount importance because they correlate very reliably with the severity of the disease, unlike in a prior sensitized pregnancy. So we see the maternal antibody status. We dilute the maternal serum into 4 parts. If it is still present the antibodies, then the mother is considered alloimmunized. Then we dilute it again to 16 parts, and then we find still there is a presence of antibody in the maternal serum. This is the critical titer. This means the antibodies are significant in quantity, and beyond this, there is a significant chance of hydrops, and the baby needs invasive testing. So this is called the critical titer. If the antibodies are maintained at 1:8 dilution or lower, all we have to do is serial monitoring of the antibody titers every 2 to 4 weeks. And depending on whether the titer is increasing, if it remains stable, this is all we have to do. We carry on till term and deliver her as usual. If the titers are sharply increasing to above 1:16, then we start instituting the fetal assessment. We start screening the fetal middle cerebral artery Doppler, assess the baby for anemia, proceed to amniocentesis if needed, and manage the pregnancy as if it was a severe alloimmunization. If this woman has had a prior affected fetus, then we can expect an increased severity of fetal disease, as I said, because of the anamnestic maternal antibody response. In this case, the maternal antibody titers are useless. So what we have to do here is to initiate the fetal assessment for anemia as early as possible. This we can do by ultrasound, middle cerebral artery Doppler for peak systolic velocity, amniocentesis to assess the level of bilirubin and indirectly the hemolysis, and fetal blood sampling. Once we detect a critical level of anemia less than 30% hematocrit, we need to give intrauterine transfusion, monitor the fetal well-being, follow her very closely every 2 weeks, try to postpone as long as possible until the baby achieves lung maturity, and then we try to deliver the baby. So how does ultrasound help in alloimmunized pregnancies? It helps us to determine an accurate gestational age, because this is very important for timing the delivery. It helps us to diagnose hydrops. We can clearly see the pleural effusion, the pericardial effusion, the ascites, and the anasarca. There are also indicators on ultrasound of impending hydrops. That is, if there is polyhydramnios or an increased placental thickness of more than 4 centimeter, if there are dilated cardiac chambers, umbilical vein dilatation, if we can see both sides of the fetal bowel, we can see a chronic hepatosplenomegaly. All these are indications of impending hydrops. Ultrasound also helps us through biophysical profile to assess the fetal well-being, and it's an invaluable guide to invasive treatments like amniocentesis for diagnosis of anemia, fetal blood sampling, and intrauterine transfusions for management of fetal anemia. So here we can see the pleural effusion and the thin rim of fluid around the fetal skull showing the anasarca. Now we come to the Doppler of fetal middle cerebral artery. The Doppler of fetal middle cerebral artery has been a boon to managing alloimmunized pregnancies, because it has reduced the need for invasive testing by almost 70%. The basis of doing the Doppler of middle cerebral artery is this: the anemic fetus tries to improve its oxygenation by increasing its cardiac output. And anemia also causes a thin blood, or a blood which is less viscous. Both these conditions increase the velocity of the systolic blood flow in all vessels. We use the middle cerebral artery because technically it is the easiest to access and do Doppler. So in the middle cerebral artery, when the peak systolic velocity becomes more than 1.5 multiples of median or MOM for that particular gestational age, it indicates that the fetal anemia is severe and indicates a further need for invasive testing. Middle cerebral artery is very sensitive from 18 weeks to 35 weeks gestational age. After 35 weeks of gestational age, it becomes inaccurate. There is a high number of false positives. So we tend to think that the baby is severely anemic and do a fetal blood sampling. Fetal blood sampling has its own drawbacks. Almost 2% fetal loss is there every time we do an FBS. So in order to avoid this false positive, after 35 weeks, it's better to rely on amniocentesis. Fetal MCA Doppler has a sensitivity of 88%, specificity of 82%, and an accuracy of 82%. This is more than the amniocentesis and estimation of bilirubin using the Lilly curve. But still, after the Queenan's curve was instituted, we'll see that in a moment, it was found that the Queenan's curve is actually more sensitive than the MCA Doppler. So in this picture, we can see the normal MCA Doppler, and on the right, we can see the MCA Doppler in an RH isoimmunized baby. We can see that the peak systolic velocity is much more. Before that fetal middle cerebral artery Doppler was introduced, amniocentesis was the gold standard for managing these alloimmunized women. So this test is based on the fact that the baby has hemolysis. Hemolysis means increased bilirubin everywhere in the fetal circulation and also in the amniotic fluid. So we take this amniotic fluid and try to assess how much of bilirubin is there, and by assessing that, we try to assess the severity of the hemolysis. So any amniotic fluid which contains bilirubin absorbs light at a particular wavelength of 420 to 460 nanometers. So we keep 450 nanometers as a cutoff, and any deviation of optical density from this 450 nanometers is measured through spectrophotometry of the amniotic fluid we take, and that deviation is plotted in the form of a graph. Lilly did this. See, there are two graphs you can see here. The one on the left is the original Lilly's graph. That was in 1953. Lilly divided this graph into 3 zones. So based on the patient's delta OD value, it would either fall in zone 1, 2 or 3. Zone 1 means mild or no disease, zone 2 means intermediate disease, and zone 3 means severe disease. So mild or no disease means she could be followed up at a 3 to 4 week interval. You could do a repeat amniocentesis, see if she still falls under zone 1 or the disease is progressing, and so on. Zone 2 a little more frequently. Zone 3, it may indicate that her fetal hematocrit needs to be assessed and she may need intrauterine transfusions. Queenan later modified this graph because Lilly's graph had some inaccuracies. Before 26 weeks of gestation, it was not accurate. Queenan modified this graph so that it could be used from 14 to 40 weeks. And this was found to be much more sensitive than Lilly's graph. In fact, it was found to be much more sensitive than even the fetal MCA Doppler. So when the amniocentesis is indicating that the baby is going in for a severe form of hemolytic anemia, that is the time when we have to do a fetal blood sampling. Unlike the other two methods of assessing the amniotic fluid, bilirubin or the middle cerebral artery Doppler as an index of anemia, fetal blood sampling gives a direct method for estimating the fetal anemia and acidosis. And as we estimate it, we can check the hematocrit. If it is less than 30%, then and there we can do an intrauterine transfusion. However, we still don't prefer FBS for all cases because there are concerns. There is, as I mentioned earlier, 2% fetal loss every time we do a fetal blood sampling. Apart from that, there are concerns like feto-maternal hemorrhage, abruption, refractory fetal distress, and amnionitis, and the maternal respiratory distress syndrome. So when we have diagnosed by all these methods that the baby needs an intrauterine transfusion, for example, the ultrasound is showing features of impending hydrops or hydrops. The Doppler is showing the peak systolic velocity is more than 1.5 the multiples of median for that gestational age. Amniocentesis, that mother's OD value is in zone 3. Fetal blood sampling shows a hematocrit of less than 30%. Then we need to do an intrauterine transfusion. Before doing an intrauterine transfusion, we have to consider some factors very cautiously. We have to consider the gestational age of the baby. Less than 20 weeks intrauterine transfusion, the fetal loss is almost triple that as after 20 weeks. So we have to make sure the baby has reached a viability period, because when we are giving the intrauterine transfusion, there is a chance that the baby may go for a fetal distress or a bleeding, which may necessitate immediate delivery. So every time we do an intrauterine transfusion, we must keep things ready for a delivery. We must have an anesthetist. We must have a neonatologist. We must do it under regional anesthesia, because general anesthesia is not good for an already compromised baby. Preferably, we must have given a steroid cover so that in case sudden delivery is needed, the baby is better prepared to withstand the complications of a prematurity. So earlier, the intrauterine transfusion used to be given through the peritoneal cavity. The only advantage was that it could drain the ascites. Intravascular transfusion is much more advantageous. We can directly measure the hemoglobin and acidosis. It reduces the procedure-related failure rate. It lowers the mortality and morbidity. The amount of blood which is to be transfused is 30 to 60 ml per kilogram of non-hydropic weight. That is, we must take the weight of the baby in its non-hydropic state. The final hematocrit after the transfusion is to be assessed, and then we decide when the repeat transfusion is to be given. That is, at the end of a transfusion, suppose the hemoglobin of the baby is 9 grams. We know that approximately once in 3 days, the hematocrit drops by 1 gram. So then, after that, we need to give the second transfusion roughly after 3 or 4 days. So we can also determine the time of the second transfusion based on the MCA PSV value. That is, a peak systolic velocity of more than 1.3 mom may also indicate that the baby needs transfusion. Intrauterine transfusion should be given only up to 34 weeks until the time the baby reaches its maturity. After that, it's better to deliver the baby because the risks of transfusion outweigh the benefits at this point. So the type of blood has to be a negative blood. We have to cross match it with the mother to make out there are no other hemolytic antibodies present. It has to have a hematocrit of 75 to 80%. The blood has to be less than 5 days old. It has to be irradiated, CMV free. There is a lot of technical equipment required. It cannot be done by anybody. It should be done at specialized feto-maternal medicine centers. So we try to manage the anemia and then we time the delivery. The timing of delivery depends on the gestational age, how severe the anemia is, whether the baby has reached lung maturity or not. As a rough cutoff, we can keep 35 weeks because, as I mentioned earlier, the peak systolic velocity of the middle cerebral artery is not accurate after 35 weeks. So after 35 weeks, if we want to assess the fetal anemia, we either have to do an amniocentesis each time, and while we are doing the amniocentesis, we can also assess the lung maturity and then decide a time for delivery. So we do the amniocentesis, the value comes as, say, as in zone 2. We feel 1 more week it can wait. That is the time when there is a role of phenobarbital. We give it in a dose of 30 milligram 3 times a day for 1 week, just to postpone delivery a little while longer. There are another group of obstetricians who feel that 35 weeks is long enough. They give a steroid cover, and instead of doing repeated invasive testing after that, they deliver the baby after 35 weeks. So one last word about alloimmunization to non-RHD antigens. So these are the atypical antigens which we mentioned earlier. Now that we have an anti-D prophylaxis for the D antigen, we see that alloimmunization is happening because of atypical antibodies, say KEL antibodies, big C, little c, big E, and so on. So in Indian population, I looked for data to see what is the incidence of these atypical antigens. There are no studies which have been done on pregnant women. However, the other group which I mentioned, that is the group which require repeated blood transfusions, those who have sickle cell anemia or thalassemia, in those people, the Department of Hematology has done testing for these atypical antigens. And they have found that the incidence of atypical antigens in our Indian population is less than 1%. Even though the incidence is so low, we have using these like we have for the antigen. So in these cases, we cannot do a universal screening for everybody because these antigens, there are so many, almost 50 antigens. We cannot screen for every one of these antigens. However, if the mother has had previous history of hemolytic disease or hydrox and she is Rhe negative, then we can think of these. It could be any hemolytic disease like Lewis antigens. Some of these antigens like anti-HEL, anti-O, anti-VW or mild hemolysis. So they can be monitored just like as we do for RHD. That is, we look for fetal anemia, try to prolong until fetal viability and then do the delivery. However, there are two exceptions to this rule. One is alloimmunization to antigens big C, small big E. In this case, unlike antigens, occurs in much less than 1:16 titers. So even when the titer is from 1.1 to 1:8,
Hello, Dr. Revati. Dr. Revati?
Yeah.
Yes, ma'am. Shall I put the next slide for introduction?
hello.
Yeah.
Yes, come now.
Can you hear me?
Hello.
Can you see my slide?
Hello.
Can you see my slide?
Yes, ma'am.
Okay. You just
Hello.
Dr. Sunita, your talk was really fantastic. Very brief and beautiful explanation about how to manage.
Madam, can you?
Am I audible?
Yes, ma'am, you are audible.
Okay. Fine. Now, after that detailed explanation about how to manage pregnancy in an RSI patient, let us have a view of, on a few cases how we are going to manage. And we have got beautiful experts with us. When I say beautiful, not only in talking but also in looking, Sumati and Yalini along with Sunita. Yalini is she was assistant professor in the Madurai Medical College, and she has got a lot of awards like Amazing Woman Award, Bharat Ratna Award, Mayan Award, and Best Clinical Paper Awards. And she has done a lot of work on endometriosis. Now, and with pleasure, I would like to include Dr. Sumati also because I think she has to share her experience in the government Rajari Hospital plus the facilities that are available that every one of us doing the practice in periphery also must be aware of the specificities and diseases. That's why I will put this committee also. And now let us move on to the first case. Dr. Yalini, she is a gravid 2, para 1, live 1. She has come to your clinic with a 12 weeks pregnancy. She is RH negative, A negative. Now, how are you going to approach her clinically?
Yes, ma'am. She has had a live delivery.
Yeah.
And I would like to know her husband's blood group because he is RH negative and nothing to worry about that. If he is positive, then I will proceed. And I would like to know whether she had any blood transfusions prior in between these 2 pregnancies, and also any previous pregnancy outcome or interventions which she had during her previous pregnancy, any antenatal bleeding episodes during the previous pregnancy, and when was her whether she underwent ICT, that is indirect Coombs test, during her first pregnancy, whether a prophylaxis anti-D was given to her and at what time it was given, whether she had any external cephalic version for breech during the first pregnancy, was the labor a prolonged one, was it an instrumental delivery or a cesarean section, whether she underwent any manual removal of placenta, and what was the group of the baby, whether she had any postpartum anti-D or not, or if she had, at what time, at when, and whether the baby had any neonatal jaundice, and was the baby now alive, healthy, and how old is the baby now?
Okay, fine. But as such, even though you have enumerated all these things, Dr. Sunita, do you think all these things must be taken into consideration, or Sunita, are you there? Sunita?
Can you hear me, madam?
Yeah.
Yeah. Because she has had one normal child, there is unlikely that she has had a major sensitization, and depends on the blood group of the first child also, and the blood group of her husband. Based on that, I think we can avoid most of these follow-ups.
Yeah. Okay. All these things are essential, but as I have highlighted, the blood group of the husband and of the baby are very important. Of course, previous pregnancy outcome, I just said para 1, but what was it like? It is also better to know. And any antenatal bleeding episodes, as such, not in the previous pregnancy, in this present pregnancy, they come at 12 weeks. Earlier, whether she has had any spotting, bleeding, or anything, that will be a better idea, isn't it?
Yes.
And of course, whether she had postpartum anti-D or not, and all those things, it is really nice. Dr. Yalini, you mentioned very aptly. Now, Sunita, what are all the, you already mentioned in your talk, which each trimester wise, what are the conditions which can increase the fetal maternal hemorrhage?
So, in first trimester, anything like a threatened abortion, spontaneous abortion, or ectopic pregnancy, or a molar pregnancy, any invasive testing we do, a chorionic villus sampling, a patient has any trauma, she falls or something like that. In second trimester, any second trimester bleeding and multiple pregnancies, because those spontaneous placental hemorrhages can occur, intrauterine fetal death, and again amniocentesis itself is a cause. In the third trimester, mainly an antepartum hemorrhage. An external cephalic version can cause a significant amount of hemorrhage. Abdominal trauma, again, these are common to all trimesters. Threatened preterm labor, and again multiple pregnancy. All these are causes of fetal-maternal hemorrhage.
Agreed. Okay. Now, during delivery, Dr. Yalini?
Yes, ma'am.
Intrapartum risk.
Yeah, if there is a prolonged labor, and there is a syntocinon induced labor, even stripping can promote this fetal-maternal bleed. Instrumental deliveries, and if it's a cesarean section, we have to pack because a lot of fetal-maternal bleed can occur, and manual removal of placenta. These are the intrapartum risk.
Okay, fine. Sunita, do you agree? Stripping, can it cause bleeding from the mother, for the mother, or will it cause the fetal metal hemorrhage also?
Which one, madam?
Stripping. Hemorrhage
Stripping can cause fetal-maternal hemorrhage, madam. Anything, any interventions.
Exactly, even if it is milder one. Okay.
Yes.
Right. Now, as you rightly pointed out in a discussion, these are all the various conditions, that is interventions, which can result in fetal metal hemorrhage antenatally. But as you can see here, the cardosynthesis takes the highest, 40%. Okay. Other things are little less, especially the Korean village sampling and all. Now, the second case is the B negative primary gravida. She had spontaneous abortion at 6 weeks. Now, should she be given anti-B or not? Right?
Yes, being a spontaneous abortion, if there is no associated pain during that abortion, or if there is no instrumental interventions, she may not need, she won't need any anti-D, ma'am. If it is just a spontaneous abortion. Because
Because it was slightly showed that the fetal tap is somewhere around 1 to 1.5%, isn't it?
1 to 1.5, there is a chance, madam. So all studies, what they say is that if when in doubt, always go for anti-D.
Exactly.
So this, we can always prevent even that 0.5% incidence, we can avoid.
We can go for anti-D, madam, in this case.
Sumati, final word. Should we give or not? Yes or no?
Should be given, madam.
So spontaneous abortion we have
positive, yes, madam. Husband is positive, better we go for anti-D.
Yeah, exactly. That point to note. Husband testing, if he is positive, there is 50% chance of the fetus also being positive, so better to go for anti-D, isn't it?
Benefit of doubt.
Okay. As Sunita rightly pointed out, whenever you have a doubt to give or not, better to go on the right side to give. Okay? Because you're not doing any harm. And what about medical? Because right and left you are going for a medical method of termination with PCV. What about medical method of termination at 40-50 days amenorrhea?
Definitely we have to. Definitely. Yeah, ma'am. Definitely we have to give an anti-D because it's an instrumentation and it's an induced abortion.
Medical method we don't do anything. We may or may not.
Of course, ma'am, but what I feel is that I will give prophylactic anti-D because it is an induced one. So most of the time it is not complete. It may go for an incomplete abortion and it may need an instrumentation to complete.
All said and done, it is not spontaneous. Even if spontaneous you are going to give, it is definitely an intervention. So better to give a talk. Vote for that. Okay. So that is the thing. Suppose she has come with 18 weeks pregnancy, she has expelled the fetus at home or wherever it is, and you have evacuated the placenta. You have to give, obviously, all of us will agree, but how much?
Yeah.
18 weeks.
According to NICE guidelines and or FOXY guidelines, we ought to give 150 micrograms for this. But according to RCOG guidelines, 300 micrograms is the recommended dose, ma'am.
Okay. Is it for this or ectopic?
For this also.
Now, what do you say, Sunita, what do you say? How much anti-D you want to give mid-trimester abortion?
Madam, the recommendation is that 10 micrograms for 1 ml of fetal blood. So if it is anything in the first trimester, 50 to 100, 150 is enough. Anything after that, 300 is a better dose. If we can accurately estimate the fetal-maternal hemorrhage and the typing of that fetus, then based on that we can give. Otherwise, 300 is a better dose.
Dr. Sumati, your opinion?
Madam, second trimester, it's go for 300 mics, madam, 300 microgram.
Okay, agree. Okay, that is the thing. And next case is an RH negative gravida 2 para 1. She has come with ruptured ectopic at 6 weeks. So all of you already told that ectopic also you have to give. Yes. And what is the dose? Ruptured ectopic at 6 weeks.
Yeah. Here only comes this nice guidelines and FOXY guidelines, ma'am. That is, we have to go for 150 micrograms of anti-D. That is equivalent to 1,500 international units. And according to RCOG guidelines, we can offer 300 micrograms of anti-D.
Okay. Right. Now, what about after molar pregnancy?
Of course, it ought to be done in the same manner.
Why after mole, does it have any antigen or does it sensitize the woman? Why you want to give after molar?
Yes.
Because it may be a partial mole or a
Fetal component.
That is the point. Unless and otherwise you are 100% sure that it is only a complete molar pregnancy, you have to definitely give. And we cannot say for sure that it is only a complete molar. It can be a partial molar, isn't it? So after any molar pregnancy, it is better to go for a anti-D. Okay. So that is the thing. So now this is 12 weeks level. Okay. Anti-D is not required. There is some few have said that before 12 weeks, if it is spontaneous without any intervention, there is no need. But as we have discussed, definitely even if it is spontaneous without intervention, better to go for it. Okay. But when there is an instrumentation or medical method of evacuation, definitely it has to be given before 12 weeks. So that is number one. In pregnancy, more than less than 12 weeks, it is only indicated. It is also indicated in ectopic, molar, diabetic termination. Okay. And all women who have ectopic pregnancy, whether it is medical or surgical, medical management of ectopic, do you give? Surgical, okay. Medical management of ectopic? Anybody? Sunita, yes.
Yes, we have to.
Yes, because most of the time it will be incomplete, ma'am. So we have to.
Not it disappears also, no? After medical management.
Whether it is medical or surgical, the amount of fetal-maternal hemorrhage we cannot assess, ma'am. So it's always better we.
Right. You agree, Dr. Sumati? Ectopic medical management? Huh?
Of ectopic, we have to give, madam.
Okay, fine. I want to make, why I am asking everyone is that I want to make it clear for the audience.
Prevention is better than cure. So we have to prevent it, ma'am.
Yes, that is it. And this is another patient. He is gravid 2, para 1. We have done an emergency cesarean section for abruptly placenta. And you suspect that there is more than expected fetal maternal hemorrhage. What are we going to do? We can't be just going on just with routine anti-D 300 microgram.
Yeah, we have to quantify the amount of fetal maternal hemorrhage by doing the flow cytometry or T-Hoyer-Betke's test, and we have to assess. We have to collect the maternal blood 45 minutes after the insult, and then these things, there is fetal maternal hemorrhage, has to be assessed quantitatively. And already Sunita had told that the maternal cells will be, it's an acid elution test, and the maternal orbices will look like ghost cells, whereas the fetal orbices being resistant to acid will be appearing as pink rose in color. So we can count them and we can assess the fetal maternal hemorrhage, 50 into the number of cells.
So the exact amount of fetal maternal hemorrhage has to be calculated, and we have to calculate the dosage. Now, okay, fine. So you have calculated the exact amount of fetal maternal hemorrhage that is occurred. How do you calculate from that how much extra you have to give anti-D? Sunita?
Madam, usually it's again the same thing, madam. For 1 ml of fetal cells is 10 microgram. So apart from the 300 microgram IM which we give, so how much the fetal blood hemorrhage has occurred, we calculate it. Usually it is not more than 2 doses. 2 doses we may have to give, not more than that usually, because that's 30 ml of hemorrhage.
Better to be a little on the higher side rather than lesser side. Isn't it?
Yes, correct.
Okay, fine.
We can go even up to 1200 micrograms, it seems, ma'am.
That is the maximum dose.
Yeah, that's the maximum dose, and in that case, we have to go for an IV.
I will come to that.
Okay, ma'am.
Now you want to give more and more and more. Do you think that this will have any side effects? The overdose or extra dose of this anti-D?
IM, I don't think there's any known side effect. IV immunoglobulin has its side effects, definitely.
yes. Even otherwise,
Because
very rarely only it is a milder side effect, only not a major issue. Okay. So that apart, you are talking about the cell-free fetal DNA. Fine, that helps a lot. Okay, to identify. We can, without, much earlier you can identify the fetuses problem. Okay. Now, do you think it is very sensitive? How accurate it is?
Yes, ma'am. This is a very sensitive test. It identifies even 0.05% of antigen present in the maternal blood, and it also helps to find determine the group of the fetus.
So it is almost 10%, you can say. Accuracy is almost 10%. Okay. Now, in
10%,
that
yeah.
case, what is the advantage, the indication? By identifying this, what benefit you are achieving by doing this cell-free fetal DNA?
We will know the fetal group, madam. The second pregnancy, we can know the fetus, group of the fetus, so that we can decide about the management.
Yeah,
If
yeah.
it is
These are the two
negative,
things. If you find that it is negative, further fetal anemia surveillance need not be there. Okay, we are very sure about it. And the tricky question: there is no need for antenatal anti-D prophylaxis.
Routine antenatal anti-D prophylaxis.
Once it is negative, it will give or not. The fetus cell-free DNA shows that fetal negative.
we needn't give, madam.
Agree?
There is no need for.
Exactly. There is no need for this. But one class is given that suppose in spite of that the patient insists that better I have for the benefit of the no other you have to inform. But otherwise it is as such it is not indicated. Okay. And this patient is second gravida para 1. Last child was 3 years ago. She is RS negative. Previous delivery she was anti-D given. Okay. Everything paka. Now this pregnancy she has come. Should we go for antenatal anti-D prophylaxis? Should we give? She has already got paka. That baby is fine, and she has had postpartum anti-D also. And this pregnancy, should we give antenatal prophylaxis?
We have to assess her indirect Coombs test, madam. If it is negative, then definitely has to be given. Unless we can assess the RH of this particular baby. Suppose it is RH negative, we needn't give. Otherwise, we have to give.
So, should we definitely go for the cell-free DNA, this, that, and all, or how do you plan to make for this antenatal anti-D for a second gravida?
we have to go for the titer, madam. ICT, whether it is positive or
exactly.
So if it is positive, no need. Already it is sensitized. So
okay. So you have to do this and then proceed with the antenatal anti-D prophylaxis. Now the question is single dose or double dose? Sunita?
Yeah.
When do you give? Actually, that is the question I asked. No, when and how you give this?
Usually,
all of us have decided that you do an ICT, and then if it is not immunized, you have to go for antenatal prophylaxis. Now, when are you going to give it?
Madam, usually, if the patient is not immunized and there are no antibodies, we give one dose at around 28 weeks. Anytime after 26 weeks, we give one dose, and then next one after delivery. Unless there have been some sensitizing events in between where we suspect fetal-maternal hemorrhage, we can give an additional dose. Suppose we've done an external cephalic version and she delivers within 3 weeks, then maybe we know we don't have to give the postpartum dose also. That's what it is mentioned.
Okay, so that is it.
Half-life is more than 6 weeks.
6.
Half-life.
Now, single dose or double dose?
If it's a single dose, it is around 28 weeks.
Okay.
If it's a double dose, then we have to give one at 28 and the second one as 34th week, ma'am.
34 weeks. Okay. I'll talk about it now. Now, as we have already told, ICT has to be done before that. Is it mandatory in all cases?
Of course, it is mandatory, ma'am.
Yes, ma'am.
Obviously, it is mandatory, and also because any patient with the RS negative, if it comes, automatically we will be doing ICT. Isn't it? So, ICT should be done, and only this non-alloimunized patient, you go for anti-D prophylaxis. Okay. Now, okay, you are giving the antenatal anti-D. Will it affect the ICT subsequently?
Yes,
Will it
it
affect?
does.
Yes, of course, it will affect.
It does affect.
We have to intubate the lab when we do ICT after giving anti-D because the
Dr. Sumit, what
half-life
is
is,
your suggestion?
uh, if it is done after 6 weeks means the concentration of anti-D is very low. In that case also we have to intimate the lab that prophylactic anti-D had been given.
No, but as such it is said that this what
No,
we give this is very weak only, so this will not interfere with the routine ICT that much, the concentration. Okay, so that is the thing. And as we have already told, if we are going to give single dose at 28 weeks, double dose it is split, so that it is given at 28 and then 34 weeks. Okay, so that is actually 125 is the thing suggested, but we go for that is half of 300 is 125, 150. So we go for 150 only, 28 and 34 weeks. So what is the rationale behind these two doses? Two dose schedule. Is there any reason or any rationale behind that? But one thing is very important. It is only under clinical research, not any guidelines. Okay. But why are you thinking of this? Thinking of it.
Any chance of any missing this sensitization dose, if it is not neutralized, madam, it will be taken over by the second dose.
Second dose. Agree?
Yes, ma'am.
Madam Sumati has rightly said that this is the reason. Yalini and Sunita also agree with that.
Yes,
Yes,
ma'am.
madam.
I do
There is
agree.
one more point also. Now, there are studies have shown that 12 weeks after the injection of anti-D, the mean residual circulating anti-D is at 0.6 nanogram, that is 5 microgram. Okay, and in some women there is no residual anti-D at all. So this may not be enough to protect against the volume of vitamin 100 more than 1 ml. So you want to spread the thing, availability of the antibody throughout. So instead of giving as a single shot, why not we try a double shot at 28 and 34 weeks divided, so that you have to maintain the level of the antibodies. But the thing is that double shot complaints will not be there, isn't it? Unlike single shot. So this is only under clinical trial and they are working on it. Okay, not yet accepted for guidelines. Now, Yalini, this patient Friday has delivered at home in a village 4 days ago, and she has just come to you for some pain abdomen or something like that, and she was found to be anemic. You have done a blood grouping and she is found to be RS negative. And when you asked her, since she delivered at home, she never went to your doctor, she didn't have anti-D at all. Now, what can you do? You want to still give anti-D?
Ma'am, I will test the baby's blood group. If suppose that is also negative, no need for any anti-D. If the baby is positive, then I will definitely give an anti-D. Something is better than nothing. So you can go up to even 24 days after delivery, anti-D can be given.
Exactly. At least some benefit will definitely be there. That is why we can defer. We need not defer. It should be given before 7 hours. But if it is missed, at least after that test is possible, better to give. Okay? So that is the thing. Now, when you give anti-D, what are the small precautions you should take? Now, these are the things, because many times either you give or you ask a junior or student to give, whether that is, because it's very, very important. The entire dose must go to the patient. We are thinking that 300 microgram is given, but only half of the thing is half in the vial itself. So it should not be like that. So you have to take at most care. Whenever you give hormones or like this anti-D immunization, all those things, the exact full dose must go into the patient. Okay.
It ought to be given in the deltoid, ma'am.
Exactly.
Not be given in the gluteal.
That's the thing over many times. Have you ever seen everyone giving in deltoid? Many times it is given in the gluteal region only. Agreed or not?
Yes, ma'am.
This point I want the audience to take home. Okay. This point I want the audience to take home. Okay, this is very important. And why? Why, Dr. Smith? Not in the deltoid, not in the gluteal, only in the deltoid muscle.
The deliverance of anti-D in full doses with that.
No, it is said that when you give in the gluteal muscle, when it goes
Madam.
the correct dose doesn't reach. Okay, so that is the reason. Now, Sunita, this B positive, BU, how do you approach? You mentioned explain about this in your talk. How are you going
Yes,
to manage in that way?
Ma'am, these antigens initially RH positive, RH negative, it was very categorical. Now these weak positives and partial D positives usually represent other antigens, atypical antigens. Unless it is an antigen like KEL, which is capable of causing severe hemolysis, the management is very similar to that of anti-D. So we monitor the baby for fetal anemia, try to keep it going until viability, and then deliver the baby. But in some of these atypical antigens, then the severity is at much lower titers. Especially, I was just saying that when it got disconnected. In KEL antigen, if the KEL antigen affects not only the RBCs but also the erythroid precursors. So the anemia is not only hemolytic, it is also a suppressive type. So we have to monitor the baby from earlier on in some of these cases. But in weak D, actually we can monitor similar to that of D only. And there's no prophylaxis. Only for anti-D there is a prophylaxis. None of these other antigens there is any prophylaxis, madam.
So in these patients, prophylaxis is not needed.
Not needed.
Now we're coming to this part: monoclonal or polyclonal anti-D. Why and which is preferred? What is the advantage or disadvantage between the two?
Monoclonal is more sensitive and yes,
Yes.
efficacy is greater, specificity is high, half-life is 18 days when compared with polyclonal, which is 15.6 days, and purity, it is highly purified, whereas the polyclonal is having antibodies and plasma proteins, and lot variations is there in polyclonal, whereas it is not there in monoclonal. The risk of transmission of viral diseases, there is no chance of risk with the monoclonal, whereas there are some chances with viral emerging virus diseases with polyclonal. And the supply is unlimited supply of monoclonal, whereas there will be shortage of supply in polyclonal.
So that is, these are the advantages and disadvantages of mono and polyclonal. Now this point, IM or IG? I think how many have you given IG anti-D?
I have never given, ma'am.
Actually, have you seen?
IV not given, madam, only IM.
We only read about it. Now, we really did not know that it can also be given
IV
IG.
preparation is available, madam, but it is the IV only we have to give by IV route, and that is available, but depends upon the preparation.
Exactly. So if it is a cold ethanol preparation, then only IM. If it is the exchange chromatography, then both IV as well as IM. So depending upon the thing, and also the severity of fetal maternal hemorrhage. Only when there is a large fetal maternal hemorrhage, more than 100 ml of fetal maternal, which is quite rare of course, but 100 ml of fetal maternal, then only you go for an intravenous system. Okay, there is a significant fetal maternal hemorrhage. Okay. Now this patient Yalini is gravid 3, live 1, ICP positive, and the Doppler NCA is, as we can see in this picture, more than 1.5 months. Sunita already explained what's next. Now Sunita, at this point I would like to just touch upon a point which you have mentioned. You said I think MCA it is a bit difficult after 18 to 35 weeks only you do, isn't it?
The accuracy of yes.
Accurate.
It's not.
Now what I thought was, after 35 weeks, what is the need? You can go to Jolly well deliver.
Yes, madam. That's what there are two groups. One who would say just give the steroid and deliver, but there they prefer to push it a little bit more till it they are sure that the baby is.
So in that case, the balance gets tilted. Waiting. If you lose, you will feel very bad.
For us to do an invasive testing, better we give a steroid cover and deliver the baby.
That's what I was thinking at that time. I just remembered and mentioned that. Okay. Now, what will you do? I need this.
And this clearly depicts that there is fetal anemia because the peak systolic velocity is very high in this metacerebral artery Doppler, and so I will, if the fetus is less than 34 weeks, then I'll go for a intrauterine transfusion.
So what are the indications for intrauterine transfusion?
Yeah,
Deciding intrauterine transfusion.
fetal hydrops, evidence of fetal hydrops on ultrasound, elevated middle cerebral artery peak cyclic velocity more than 1.5 norms, and in Lilly's curve, if it is in zone 3 or zone 2, and 2.7% there is total risk of fetal loss when we go for a intrauterine transfusion.
But Sumati, do we have the facility for IUT in our hospital?
No, madam. Unless a
Is there anybody doing it in Madurai? Anybody doing it in Madurai? Because we are all the time we are referring to Chennai or Fetal Medicine Center where they do this.
Yeah, referring to Trichy, ma'am, where there is a fetal maternal unit.
in collaboration with the fetal maternal unit, madam. In that case, if the fetal medicine unit is there, we can get the help from them, and we can also do that, madam. At MMC, they are doing with the IOG and ICH institute. They are doing it, madam.
Exactly.
So here we are not having
But
the
exchange
facility.
transmission, exchange transmission, we are doing no.
Exchange transmission, yes, madam. Yes, they are doing.
Yeah, that is facilities are available, isn't it, sir? So what is the role of exchange transmission in severely affected newborn? Dr. Sunita?
Madam, there is a definite role. If the baby is beyond the period of viability, it gives good results, madam. As soon as the baby is born, we do a fetal hematocrit and then do an exchange transfusion based on its body volume, and then it gives a good response, madam. Sometimes 2, sometimes 3. Usually, depending on the hematocrit, they decide once in 2 days or something like that. With phototherapy, continuous phototherapy, they do that.
Serum bilirubin values more than 20. Yeah, exchange transfusion is advised, ma'am. O negative blood has to be transfused.
Yeah, exactly. Right. Now, before we conclude, Dr. Yalini has told me about an interesting case to met with. And this morning only we listened to Dr. Jayakishna about recurrent miscarriage, recurrent pregnancy loss, isn't it? Now, this patient was a 34-year-old RH negative with a history of 9 abortions. Now, you tell Dr. Yalini about the details of the case and what could be the possibility and how you want to manage her.
Yeah, all the abortions occurred between 14 to 18 weeks, ma'am, and all due to hydrops fetalis. She hadn't received any anti-D after the first abortion. Maybe that may not be a sensitizing one because usually on the first antibody that is produced is IgM, which will not cross the placental barrier or it does not produce. But I'm not sure whether that alone has sensitized her. Maybe second or third abortions definitely should have been sensitized. And her husband's group, I mean, whether I want to know whether he is homozygous or heterozygous because it is done in all AIMS hospitals.
Just a minute, Yalini. Dr. Sumitra and Sunita, you tell us the possibility that how are you going to link this sort of a bad obstetric with RH?
Madam, usually in bad obstetric history, if the mother has had a previous history of hydrops, the chances in severe pregnancies are going to go on increasing because the maternal immune response worsens after each such episode. And also, when it is less than 20 weeks, we cannot even manage her with a fetal blood transfusion because the chances of fetal loss are very high if it is given before 20 weeks. And when the onset is so early, from as early as 14 weeks, the likelihood of another antigen like KEL or something like that is very high, madam. KEL typically presents around 14 to 16 weeks of gestation and it is typically very severe. So it is in these cases that the role of IV immunoglobulins was being investigated. There are some positive results. That is, they give IV immunoglobulin in a dose of 1 milligram per kg per week. And then they repeat it weekly. And this is supposed to reduce the incidence of this severe immune response until the time when the intrauterine transfusions can be instituted for the baby. If we attempt a intrauterine transfusion so early, it is not only impossible, but the fetal loss is very high, madam. So after 24 weeks, we can give. Until then, the only way we can try to do is to give IV immunoglobulin. Some papers are there which say that you can do a plasmapheresis and then you can give an IV immunoglobulin and that gives a better result.
Okay. The first loss cannot be due to RH. The subsequent this much of loss, can it be due to some other cause, the hydra due to other causes other than anti-D? Other than RH?
Can be other antigens or it can be some other, but anything, even if it's some infectious disease, such a recurrent bad obstetric history, it doesn't cause me.
Okay, anyway, forgetting those part of the cause for these things. Suppose she is sensitized, already severely sensitized woman with no lifestyle. She wants to have a live baby. What are you going to plan, Dr. Yaini?
Yes, ma'am. I would like to know the zygosity of her husband, whether he is homozygous or heterozygous. It is being done in Delhi AIIMS and in all other AIIMS hospital in our country, and it costs around 10,000 rupees to do the find out the zygosity. If it is heterozygous, there may be a 50% chance of having a live fetus, a live baby. If he is homozygous,
in that case, he's already heard, no? He has had this much of pregnancy loss, isn't
yes,
it?
ma'am. So, I think I will counsel the couple, and I will advise them to have an AID of RH negative semen.
ART specialist view. Sunita also agree with that?
Ma'am, she's already pregnant now. So if we give immunoglobulin, maybe she'll deliver safely.
That's any other options you have got?
Amniocentesis, madam. Amniocentesis and any role for analysis.
Now this is really a tricky area. Number one is that the first baby itself is lost, so that cause we do not know. And subsequently, all are around this 14 to 18 weeks, whether it is really due to the RH or not. And if so, it is very, very difficult to manage. And whatever we plan for a hydra, suppose if you allow her to become pregnant again, at 14 to 18 weeks, if the baby shows hydras, as Sunita rightly pointed out, there is absolutely no way for intrauterine management also.
She was not pregnant, of course.
Not now. If allow her to become pregnant.
She's not pregnant, Sunita.
Practice.
Okay.
No, she was pregnant. She was not pregnant at present.
Okay.
Okay. In case we allow her to become pregnant, there's no option for us to manage her also. So these are the very tricky areas. Forgetting about all this bad obstetric, 9 bad obstetric, but thinking that erase all this, thinking that she is RH negative with no live child and she is severely immunized, how are you going to tackle her? Right from counseling pregnancy and management part. One option is straight away go for donor resisting and then get away safely with the negative baby and give her a live baby and send her out. Other options.
If there are other atypical antigens, we cannot screen for all the antigens, madam. Even if we do with the RH negative, if it is an atypical antigen, we cannot screen. There are more than 50 antigens. It may not be possible to assure her that she will have a 100% safe outcome unless we know what the cause is. So,
and there is one possibility that the positive RBCs can be given to the mother to desensitize her as capsules. There is one thing going on. And the other one is we can implant O negative bone marrow into the fetus so that O negative cell line will be also there. So there will be production of O negative RBCs. So the baby will not become very anemic. So
there are not reached, but still possibilities. Okay.
Madam, why can't we go for IVF with select? implantation, genetic testing and confirmation, and then she can go for it.
Yes, options are there like that only. Okay. So, Dr. Sumati, what are all the facilities available in our hospital, GS, for managing this RH, apart from giving anti-D? Number two, are you in government hospital? Are you giving the routinely the antepartum, antenatal anti-D?
No, madam. We are not giving antenatal prophylaxis, madam. We are not able to give because of the fund allotment and other thing. And also when we are doing for postnatally and as well as post-abortal, and we are giving. And then for the second pregnancy, if the patient comes following this delivery, we can do only ICT, that is positive or negative only. We are not having a titer level also, madam. That is also difficulty in judging for us. We are doing ICT. And then we are deciding about whether it is negative or positive with ultrasound findings, and whether the fetus is affected, like that only we are going for, madam. No, also amniocentesis and other analysis also is not possible for us. Still we have to go for a fetal medicine unit. That will be better if we have.
This is an eye opener. That youngsters, please go for training in the fetal medicine and then open fetal. Previously, everyone was so eager to start an ART center. Now you better learn and start a fetal medicine unit in Madurai. That will be a good choice in future. Now we have got some questions from the audience. Go to the questions from the audience before take a message. Shall we?
Yes, madam.
Now, Dr. Sunita, what is the earliest sign of hydrops on ultrasound? This question is from Dr. Sobita.
Earliest sign is usually fetal ascites, madam. And the last sign is usually the anasarca, the subcutaneous edema is usually the last.
So, have to carefully monitor them with the ultrasound, okay?
We can just see a thin rim around the liver and spleen. That's usually the first.
Okay, fine. Now, the question from Dr. Rangalakshmi, should all RH negative mothers be delivered at 38 weeks or to be taken to term?
We don't allow postnatal.
That is clear. Nobody will allow postnatal. But should they deliver at 38 weeks itself or allow up to term?
If she is not iso-immunized, we can allow her up to term, madam. If she is iso-immunized, then we should deliver by 37, 38 weeks once we are sure that the baby is mature.
Now, another question she has asked is, if ICT is negative and there is no USP markers of alloimunization, and the patient can be allowed to go for spontaneous onset of labor and delivery. As we said, we will not allow them to go beyond term. So, what is the best mode of induction? You have waited till the time. Is it just like routine or anything special? Mode of induction. Anything special? I don't think.
Madam?
Only thing is that we have to keep everything ready for managing an RS delivery. Okay. And Dr. Sunita, question from Dr. Vijay Lakshmi. Antenatally, no. This is from Saroja Velusamy. How early we should do ICT? And
we can do from 20 weeks itself, madam. And then we can 20 and 28 is enough. If we want, we can do at the middle also. Once at 20 weeks and once at 28 weeks. And if it's still negative, we can give the antenatal prophylaxis at 28 weeks.
Sumati, you also agree with that?
Madam, still earlier also we can do, but it is ideal 20 weeks, madam. But 14 weeks also we can do it.
20, 24 and 28 weeks.
Yeah. 20 weeks is ideal, okay, to start with that. And repeat every 4 weeks, okay. And of course, 28 days, twice it is negative, it is unlikely, okay. And obviously, when it is negative, you go for anti-D prophylaxis. Antenatally, when we give anti-D for second pregnancy, if she had anti-D after the first stage, yes, exactly. See, that is why I stressed that point. That case presentation I gave only for that. A woman who has had, a lady who has had anti-D postpartum with the first delivery, The second pregnancy also she has to be, because the half-life of the anti-D we have given is gone. So for this present pregnancy, to get immunized, to prevent the immunization from the present baby, we have to necessarily give antepartum anti-D. Agree?
Yes,
Now, this is Dr. Vijay Lakshmi question. Is it clear, Dr. Vijay Lakshmi? And when wife's blood group is positive and husband is negative, then what precaution we should take during antepartum and intrapartum? Dr. Gauri John. It is obvious, we have already told, no, positive is a negative. Okay. During antepartum period, likelihood of the baby be safe. She is asking. Wife is positive, husband is negative, absolutely no problem. Always the negative mother is the problem. Positive mother is not at all a problem. And positive mother cannot be either this homozygous, heterozygous, all these problems are not going to be there at all. Even if she is heterozygous, capital D small d, and even if the husband is negative, small d, and there is every chance that she cannot have a negative baby. I mean, positive baby or immunization and all those things. For immunization and the subsequent complication, only for a negative mother. That point you have to be very clear about. Okay. And if patient has taken anti-D at 32 weeks and delivered after 1 week, should anti-D be repeated postpartum? Into Kumari.
No need
No
for
need,
an
madam.
anti-D.
If at all we can assess.
If the fetal bleed is heavy means, then we can assess the quantitative measurement of
Then if needed, we can give a second dose.
Sumati, do you agree with that? Whether it is 28 weeks, if we give, we have to definitely give during postpartum anti-D. If it is given, why they have given that 32 weeks, we don't know. If it is given at 32 weeks, should we repeat this postpartum anti-D or not?
Better to be given, madam.
That is what I do agree with that. That is why I asked you. Okay, I agree, because we do not know how much of fetal maternal hemorrhage is going to occur during this delivery. So it is, even if they are given anti-D prophylaxis antenatally, better to give this postpartum. Okay. I mean, multi-gravid, agreed?
In government hospital, they have only postpartum anti-D, ma'am. So they will be definitely giving it.
So irrespective of antepartum, okay. In a multigravida, when we don't know about the immunization status in the previous pregnancy, when should you go for ICT? That we have already told. Now, I think she thinks Dr. Sadia, she wants to know earlier if you do ICT or not.
Yeah, during her first visit itself, we have to do the ICT, ma'am.
That is what she wants. Okay.
Yes.
So if she suspects that the possibility of alloimunization would have occurred, definitely it's better to do earlier. Okay. Can cesarean section reduce the chances of erythroblastosis fetalis? I don't know. I can understand this question. How can a cesarean?
Of course, it will increase.
Not a cesarean section. You want to know what the termination of pregnancy. Cesarean section per se, how can it prevent hydrocephalus, erythroblastosis? No, it is not erythroblastosis fetalis. Now I don't know. I don't understand this point. Why she asked that? Now the thing is that when you conduct delivery, now the important point which I want to share with all the audience is that every woman of childbearing age should have her ABO grouping and RS typing done in the first contact itself. And husband's typing also must be done. And ICT is done at 20, 24, 28 weeks or as 20, 28 weeks. And you have to give them, if negative, antepartum anti-D prophylaxis must be given. And a single postmortem dose may be inadequate in cases when there is severe fetal maternal hemorrhage. Now, very, very important thing is that all immunized RS negative mothers should be referred to higher centers where there is facility for fetal medicine. That's what I was discussing. And remember one thing, RS negative is a high risk pregnancy. So when you are going to handle that pregnancy, you should know about it, how to manage it, in case any complication arises, how to tackle it. And even if it is a normal delivery, reserve and keep a bottle of negative blood. Make sure that it is available, because we cannot predict postpartum hemorrhage in any of these patients. I have seen a patient being delivered because our people are so confident that cesarean section I can do in 10 minutes without blood loss. So at Shivagasi, somebody has done repeat cesarean with sterilization for a RH negative woman, torrential bleeding, they have not planned for any blood transfusion at all and landed in big problem. So even if it is a normal delivery, you should keep arrange for blood if should be made available at least. And during delivery again, all the precautions timing of delivery also, precautions you should take at the time of delivery again. Early cord clamping, that is again very important. The delayed cord clamping is the one we talk about in the active management. Here it is delay early cord clamping because you don't want any amount of antibodies if at all present in the mother to get into the baby. No milking of the cord and no manual removal of placenta and always cord blood sampling. All these things, all of us know, but still I would like to insist on that. And I think with all these points in mind, definitely all of us will be confident enough to manage RH negative mothers. And even if they have undergone previous complications, we have learned now how to manage such problems. Any other point you would like to add, Dr. Sumati?
Madam, almost we have covered everything, Madam. It was so good.
Okay.
Madam,
Okay,
there is a school of thought that we can, no need for this early clamping of umbilical cord because the baby will be benefited because most of the RH negative babies are anemic. So we can allow the.
So in that case, what about oxytocin? Spirit was telling better to avoid oxytocin, isn't it? What about oxytocin? Should give you oxytocin and fear about fetal hemorrhage or not giving oxytocin, fear about PPH?
We can. PPH is more dreadful than this.
So at least we can manage fetal hemorrhage with anti-D, but not a PPH so easily.
We have to go for oxytocin.
Okay. Now, is anti-D available for primary patients who diagnose RH negative during antenatal? It is available. You have to give. And repeated presence plus preconception investigations and counseling. Already, I told. Okay. And lot of questions. Very nice. And do you suggest quantifying the fetal hemorrhage in some high risk conditions? Yes, whenever you anticipate extra or huge fetal hemorrhage, you have to quantify that. Only then you can cover all. You can give a good amount of anti-D. What are the chances of sensitization of anti-D is not given? Dr. Sanjeev Shah. Chances of sensitization. Dr. Sunita, is there? Dr. Sumati, if anti-D is not given, if anti-D is not given, what are the chances of sensitization?
Not given.
So depending upon the amount of fetal hemorrhage, extent of fetal hemorrhage, definitely, even if 0.1 ml is enough to sensitize that. Not
16%. Almost 16%. 16%. Madam.
So that is why by giving this anti-D, we have brought it down to
less than 1%.
1%, exactly. This study have already, I think, this Dr. Sarita Srikanth, she has not attended the earlier part of the discussion. She is asking early pregnancy terminated with pills. That is medical method of termination. Should we give anti-D? We said yes. All of us agree. Okay. I think with all these questions, almost all questions we have answered. Okay. So I thank all the, I can't say panelists, all the participants. Dr. Sumati, I am very happy and thankful to Dr. Sumati for involving in this. Because suddenly I thought she should also come and participate and then give her opinion about what best we can do in because every one of us having a very bright idea that GRS means it is great. Everything is done there. So that idea would have come. So I would like to know what all the things done in the university also in our case. Okay. So I thank Dr. Yalini and Dr. Sunita also for their wonderful presentation as well as interaction. And I thank all the audience for listening to this and participating with putting in a lot of questions. It gives us to learn more and give you the answers also correctly. Thank you very much and thank you so much,
madam. Thank you, madam. You make it very lively, madam.
Yeah, very lively, madam.
Thank you.